Welcome, everybody. We're so excited to have you with us today. And I think this is going to be a really incredible discussion about COVID-19 and the DEEs, or the rare epilepsies. And we know that there are still a lot of questions out there, and we're hoping that today we can start to um, address some of those questions. So for those of you who don't know me, I'm Gabi Conacher. I'm co-founder of Deep Connections. And we have been working for about 2.5 years to address the concerns of rare epilepsy families and bring resources and information to the community via our webinars. So the goal of the webinar today is to share the latest information that we have about COVID-19 experiences, both with vaccines and with infections for those who are living with rare epilepsies. And there's not a lot that we know yet. There's not a lot of data that has been collected about this population. Dravet Syndrome Foundation led the way with a really fantastic study that they did on vaccination in those with Dravet syndrome, which Anne Berg, who's with us today, was a co-author on, and Veronica Hood, their science director, led that effort. And that's a really important study, and it's one that I refer a lot of people to when they ask, because it's pretty much the only study that we have that talks about this population. So I'm going to drop this off so we can see each other. I just want to make sure people know who we are, if you're in the right place, hopefully, if you're seeing that slide. So that study, which was really important, that was really looking at vaccination, which is often a trigger for seizures in that population. And they had some really compelling findings in that, which is that 50% of those who were vaccinated had no side effects, and there was no status epilepticus events that came as a result of that. 13% did have some increase in seizures, but overall, the idea is that the vaccine was really well tolerated in that population, which is a high risk group, even among the DEEs. So those are some really reassuring results for caregivers of those with Dravet, and potentially for the wider DE community. But our goal with what we're doing now is, with this webinar, we're kind of starting a conversation. I looked back, and we actually, Deep Connections hosted our first webinar on COVID-19 back in March 2020. And that was really cutting edge, information then. And we're hoping that today we can share all of the latest research that exists, which is not necessarily directly addressing, those with developmental and epileptic encephalopathies, which are these kind of more rare epilepsies where there's epilepsy present, but also accompanied by developmental delays. And often these are epilepsies that are refractory, where seizures are really difficult to control. And so our goal is today to kind of share some of that. And in conjunction with the webinar today, we are also doing a survey of the DEE community, which Dan Freedman is our principal investigator down at Dell Children's. This is an IRB approved study. It takes just about 10 minutes. And what we're doing there is really looking to see, to learn from all of you. You all have the best possible information about what's happening with COVID and our community. And we're hoping that you will fill out this survey to help us learn, because currently we have about 60 people who have filled it out, which is amazing. It's the beginning of being able to see, but there's a lot of diversity in there from different age ranges, lots of diagnoses. And for the most part, people, it seems like with these DEs are doing fairly well, very well with vaccinations and pretty well with infections, but we have so much more to learn, and we really need a large group of people to fill that out for us to really get a better sense of where the community is and what's really happening. So I'll share a little bit more about that towards the end, but we'll really appreciate your help, and I'll also post the link to that. I am going to quickly jump into introducing our guest today so that we can dig into the meat of what we're hoping to get to today. We have joining us Anne Berg. She is an adjunct professor of neurology, epilepsy, and clinical neurophysiology at Northwestern University, but also works at COMBINEDBrain. Tina Sosa is an assistant professor in the Division of Pediatric Hospital Medicine and an associate chief quality officer at Golisano Children's Hospital in New York. And Dan Freedman, who's an assistant professor in the Department of Neurology at Dell Medical School, and a board certified pediatric neurologist at University of Texas Health Austin Pediatric Neurosciences at Dell Children's in Texas, which is a very long. And we also have Tracy Dixon-Salazar, who's going to be joining us in a little bit towards the, a little bit later in the webinar, who is the executive director of the Lennox-Gastaut Syndrome Foundation and mother to a young adult who has LGS. So I'm going to go ahead and pass it off to Anne, and she's going to give us some of the bigger picture. And from there, we're going to move on to Dan and then Tina, and then please throughout be throwing your questions into the Q&A. We will be monitoring that and addressing as many as we possibly can at the end. And feel free to use the chat as a place to share thoughts, ideas, things that resonate, things that come up for you as we're going through. So Anne, the floor is yours.
There we go. Thank you, Gabby. Is that showing okay?
Yep, that's perfect.
Are we good? Okay. Let me just close this so I can see better. Well, thank you. And thanks to all of you for joining us. What I'd like to do in the next few minutes is just give you sort of the big picture perspective on COVID-19 in the population, and talk about give you some information so you can weigh the risks and benefits associated with vaccination versus running the risk of infection. So I'm going to talk about the COVID-19 infection in the short term and long term, the benefits of vaccination with respect to the COVID-19 infection risks, and also the risks associated with COVID-19 vaccines. And then we'll try to put that together, but there are a couple of missing pieces that we'll have to acknowledge as well. As you know, at the beginning of 2020, end of 2019, really, we were hit with this pandemic. And to date, the most recent figures from this morning are that in the United States, we've had almost 90 million people who have had COVID infections and over 1 million deaths. Globally, it's been over 500 million people and over 6 million deaths. This is what the death rate looks like, just week to week over the past year or so. And you can see that we're still on average having about 1,600 deaths per day. It sort of varies up and down, and that's partly a reporting issue, but we're having over 1,000 deaths per day in the United States. It's not as high as it was when this first started, but it's pretty darn high still. In addition to mortality, which is our biggest concern with COVID. I mean, it's a terrible illness, causes a lot of acute morbidity and mortality. But in addition to that, there are post-acute COVID-19 syndromes. And we've talked for a long time about long COVID. And long COVID involves a lot of what you could say are subjective symptoms, such as fatigue, hair loss, maybe not so much, hyperhidrosis, excessive sweating, not so much, but fatigue, insomnia, anxiety, arthralgia, memory problems, chest pain, but a lot of it in people following COVID infection. In addition to these somewhat more subjective concerns, there's a clear autoimmune syndrome going on, the post-COVID inflammatory syndrome, and this is seen in both adults and in children. One of the most important serious aspects of this is myocarditis, inflammation of part of the heart muscle. These are data from the CDC. It's really myocarditis, pericarditis together. And in the general population without COVID occurring, we would expect about 9 cases per 100,000. I think that's per year. Following COVID, we're seeing about 150 cases per 100,000, so 16 times higher risk. And there are other conditions that we're starting to look at, as the aunt of an 18-year-old who had COVID in 2020 before vaccinations were available, and now has an insulin pump. I'm acutely aware of the potential other medical complications associated with COVID. COVID is slowing down, it waxes and wanes. This is what it looks like globally over time. And these are as the different variants were coming out. I think this is Omicron, and now we're going to this B2A. But there's still a lot of it there. And as far as we know, it's going to be with us for quite a time, and we're going to have to deal with it. So there are a few things we can do. Before we had vaccinations, we isolated and masked, and I'm sure all of us are tired of being isolated. And the isolation has a huge number of health consequences and quality of life consequences as well. And the masking, let's face it, it's not pleasant. Our best weapon against COVID, though, is vaccination. And really, vaccination, it has been controversial in the past, but I think it's irrefutably demonstrated to be one of the most important public health maneuvers that we have. It has greatly reduced the occurrence of a wide number of infectious diseases, and it has decreased mortality, increased life expectancy, and quality of life. The COVID vaccines came out very quickly. That was a miracle of science. Thank you, scientists. And in the US, predominantly, we've had 3 vaccinations available from Pfizer, Moderna, J&J, and just last week, the Novovax vaccine was approved by FDA. The first 3 use a novel technology, which has actually been around for a while, and it's not that it just was developed last week or a couple years ago. It has been in development for quite a while, and that's the messenger RNA or mRNA technology. And the one that just came out is protein-based, like our older vaccines. These vaccines, though, provide a huge degree of protection against COVID. This is a huge table. I don't want you to read everything. I've circled some of the vaccines that we have in the United States, and this is a common one used in Europe, AstraZeneca. And in the blue, what you can see is the protection against any infection, and that ranges from 63% for AstraZeneca up to 92% for Moderna. Against severe disease, because people still get infected, we're seeing high 80s to mid 90s% infection protection against severe disease. That was for the what we've called ancestral strain, the first strains that came out. We've kind of learning the Greek alphabet as we go along. You can see for the more recent Delta and Omicron strains, very high protection against any infection, not perfect, against severe disease, pretty darn good. So it doesn't protect you entirely from getting sick. So does it matter? Some people would say, well, I'm going to get it if I get vaccinated anyway. Well, it does reduce your risk. But here's the thing. I've talked about the long COVID syndrome. It also protects, if you do get sick, even though you're vaccinated, it protects against that long COVID syndrome. This is a remarkable study that was based on a few million people, but 25,000 of these people had already been vaccinated, but they had breakthrough COVID infections. And they were carefully matched to 25,000 people who had COVID infections, but had not been vaccinated. And over 90 days, in those who were vaccinated versus not, we see lower mortality, less development of hypertension, less thyroid disease, less venous thrombosis, which is a concern with COVID. I'm not sure what they mean by mental disorders, but there's less of them. And of those long COVID syndrome, more subjective concerns, less fatigue, less body ache. So even if you get COVID, your risk of serious infection is lower and your risk of longer term consequences is decreased. Are these vaccines safe? We have data like you would not believe. This was a study of over 6 million people and almost 12 million vaccine doses of all ages. The younger ones somewhat less represented because this came out last year in 2021. And these people looked at the risks of a wide range of potential medical complications following COVID vaccination. And what they found compared to the population was negligible increases in risk for almost everything, a little increase for myocarditis there, a clear increase. This is excess per 1 million people. So if you have 1 million people who are vaccinated, you might find 7.5 more cases of venous thrombosis on average per million. What they did find, though, when they dug into the data a little bit, was a bit of a signal in younger men for myocarditis, particularly in men and particularly in the week following the second dose of vaccination. Of those who develop myocarditis, which is not, it's not a minor complication, but it's rarely fatal. Most of them did end up in the hospital, only 2 in the ICU, and all have been discharged home and are recovering or recovered. This has persisted, though, and it is a concern. In this other study, more recent study, the investigators looked at the Pfizer and Moderna vaccines, first, second dose, and risk of myocarditis. And you can see that after Pfizer, after the first dose, 15.6 per million doses, risk of myocarditis, a little bit higher for Moderna, not hugely so. After the second dose for Pfizer, it almost doubles. After Moderna, it almost triples. And what's going on is that in younger men, especially with Moderna, we're seeing a very high rate of myocarditis, 300 per 1 million doses. That seems really high, and I'll put it in perspective in a minute, but the investigators also identified some maneuvers, including spacing the doses apart more, that could help reduce that risk. Remember, I showed you those CDC data per 100,000. I made it per million. Without COVID, we would expect 90 people per million, not 100,000 per million, to develop myocarditis. With COVID, it would be 1,500. With the vaccination in the highest risk group, young men after the second dose, it's 300. So just to put that risk in perspective, it's nothing to sneeze at, but please remember it would be much higher if people just get COVID. I want to mention briefly also what happens. We don't have good data. This is one of the missing pieces. We do not have good data for children with epilepsy, particularly DEEs. And this study by LaRovery and colleagues from 2021 is really critical. They looked at children who had been hospitalized for COVID. And there are a couple of things that really struck me. Of the pediatric patients who were hospitalized, 11% had pre-existing neurological conditions. I don't mean minor things like, some learning disorder. I mean epilepsy, neuromuscular conditions, serious neurologic conditions. 6% had pre-existing epilepsy. Only about 0.5% of all children in the population have epilepsy. This is 10 or more times what you would expect in the general population. Of children who got hospitalized, remember that multi-system inflammatory syndrome, it can be acute as well. And a certain number of children, 22% altogether, develop neurologic involvement as a result of having COVID. Of those who developed neurologic involvement versus those who did not, they were more likely already to have pre-existing neurologic conditions, including epilepsy. Those who had neuro-COVID ended up in the ICU more, required ECMO, mechanical ventilation, and they had higher death rates. So it's not a direct comparison, but children who already have neurologic conditions are at increased risk of a worse course if they're hospitalized with COVID. So when we put this all together and think about it, without a vaccine, we have a huge amount of morbidity, acute morbidity from the infection itself, high hospitalization rates, significant mortality. Right now, it's running on the order of maybe 1%, and that's pretty significant. We have the risk of long COVID, the more subjective feelings, but there's clearly this multi-system inflammatory syndrome that may follow us. We don't know for how long. Vaccines do not stop this dead in its tracks. Let's be honest about this, but they decrease the likelihood of getting infected. If you get infected, they decrease serious disease, they decrease mortality, and they decrease being vaccinated means that you are less likely to have post-acute infection complications. I hope I've convinced you that the serious risks associated with vaccination are minimal, and the worst ones, things like myocarditis, pale in comparison to the risks associated with the infection itself. What we don't know yet are the risks specific to medically complex individuals. And this is really critical. I can give you this information based on millions of people, but what you decide for your child, please take this information, discuss it with your pediatrician, discuss it with your other care providers, because there may be something very specific to your child that might weigh you in one direction versus another. Regardless of your child's vaccination, I urge you to take care of yourself. Please get vaccinated. You will decrease transmission risk to your child with DEE and to others in your community, but particularly to your child. And you have to keep yourself healthy, because who else is going to take care of your child when you get sick? Having trouble moving that. If you could please complete this survey, the Deep Connection survey that Gabby mentioned, you can help bridge this gap in knowledge. It's available on the Deep Connections website. Real quick, if you grab that QR code, you can fill it out. It's at this website, but I think your best bet is to go directly to Deep Connections. So with that, I think, yeah, I will turn it back to you, Gabi.
Thank you so much, Anne. That was very compelling. Lots of great data. I think we'll go straight to you, Dan.
Awesome. Let me share my screen. Y'all see that okay?
We see the next slide. I think it's shifting though. There we go. Full screen.
Okay, perfect. All right, so I wanted to focus on the kind of what I've seen and what other neurologists have seen with some of our DE patients and how COVID has impacted them. So like Anne was saying that, you know, luckily children are spared some of the worst of COVID. It is a kind of weirdly age-related disease. The highest risk population is still going to be an older population. And a lot of kids are going to have mild illness. Most kids are going to have mild illness. Unfortunately, it's not a guarantee that all kids are going to have a mild illness. And so we definitely see kids that have significant complications from COVID infection. And as Anne touched on, there are harms that go way beyond the virus itself. And it's in some ways changed the way that we even practice neurology. So with some of these indirect COVID harms, we've seen certainly during lockdowns, there's decreased access to resources. Appointments had to be pushed back. Our epilepsy monitoring units were closed for a time, so we couldn't get patients in the hospital to monitor their epilepsy. We've fundamentally changed the way that we treat infantile spasms. So infantile spasms was something that we would urgently get kids in the hospital, get them started on medication, and early in the COVID pandemic, there was a push to try to minimize inpatient time for these patients because these are kids that we put on high dose steroids. We're putting them into an immunocompromised state. So we purposely want to keep them out of the hospital where there's going to be all these, you know, respiratory viruses circulating. And so we very intentionally shifted the way that we treat that diagnosis to help minimize the risk kids have of getting COVID. I've heard from a lot of my families that finding help is harder even now, 2 years into this pandemic, because there's been a lot of people, there's kind of a lot of burnout within healthcare, so nurses are leaving the workforce. We have some people that don't want to get vaccinated, so they don't want to be, someone doesn't want them to be a home health nurse because that nurse is unvaccinated. So there's lots of caveats that kind of uniquely affect our population. And then the virtual visit thing is a double-edged sword. It's been amazing in terms of getting access to patients that we didn't previously have access to. So one of my patients comes from 6 hours away, in a wheelchair, has a hard time getting around. And so the idea that we can do the virtual visit and check in much more frequently than we could have for in-person visits is game-changing. But the flip side of that is that I have lots of patients that need physical therapy, occupational therapy, speech therapy, and so much harder to get in a virtual environment, especially for the long period of time that things were strictly virtual. Now we're starting to, get back into physical in-person appointments, which is really great. And we have to balance that, of course, with the risk of doing those things. And so I think the most important thing is that DE kids, just like any kid, can't live in a bubble, right? We can't, and that was my recommendation early in the pandemic, before vaccines, even when we first got vaccines, and it was for adults only. I said, make sure that we kind of protect everybody around the child to make sure that we are creating this like ring vaccination, basically. And everyone around them that's in contact with them, taking care of them, needs to be vaccinated, needs to be, you know, wearing a mask, washing their hands, all that kind of stuff. And that's true. We honestly recommend a lot of stuff even pre-COVID, because anytime I put a kid on steroids for epilepsy, I want to make sure that people around them are vaccinated, people around them aren't visibly sick or actively sick. And so we try to do all these kind of risk mitigation strategies all the time. But it's important, especially important now that we have this highly contagious pandemic virus. And as Anne touched on, we have this, you know, critical issue of caregiver physical and mental health. So making sure that you have access to resources, making sure that you're taking care of yourself, protecting yourself from this virus too, because if you get sick, you need someone to help you care for your child. So having all these complex issues that kind of uniquely face our population is, it's been a struggle, and it's been frustrating for everybody, I imagine. So I think vaccines can kind of help in lots of different ways, both directly and indirectly. Specifically, what I've seen in pediatric neurology, I had to take a step back from DEEs and just include everybody that I see in neurology, because I do kind of a little bit of everything. I do general neurology, epilepsy. I have my kind of difficult to treat epilepsy patients, and then I also have my I have a clinic where I get a lot of unusual neurological symptoms that are also resistant to treatment. And so because of that, I kind of have a unique referral bias. And so I do see some long COVID in previously healthy kids. I've also seen a fair number of new onset chronic headaches. We definitely see increased seizures in kids that have epilepsy when they get COVID. We've seen febrile seizures in kids that did not have epilepsy. And then there's also been some association with developing Guillain-Barré, which is a severe nerve disease that you can get. It's not a strong association, but it's something that we see with other respiratory viruses too. And so it's not unexpected that we might see that in association with COVID. And then the main reason I got involved in this project, and I was really excited that Gabi was putting this together, is that I had this really unfortunate, really sad story of a patient that had epilepsy, was already had a pretty severe epilepsy to begin with, and then got COVID, was in the ICU for a very long period of time, had really complex respiratory involvement from the COVID, and then also, unfortunately, developed worsening seizures and kind of a new neurological baseline as a result of this prolonged hospitalization. So it was really, you know, hard to see and hard to take care of her and help the family adjust to this new normal. And so it was all, this happened pre-vaccine, so there would not have even been an option to vaccinate the child, and just making sure that I can hopefully prevent other parents from having to go through that, and other kids from having to go through that. What other people I work with have seen, specifically in DEE, lots of people report seeing seizures worse when they get COVID. Again, not terribly surprising when we have a lot of epilepsy syndromes that we know will worsen with fever. So you get sick with any virus, you're going to probably have a fever, and then you're going to have worsening seizures. There have been other case reports similar to the patient I took care of, where kids with Lennox-Gastaut, other things, developed severe lung infection. And there's reasons for that too, because a lot of our kids have respiratory support to begin with, so then they're more likely to develop respiratory complications. And then one of the weirder things I found in talking to people and looking at case reports in the medical literature, there's been a fair number of cases of infantile spasms having relapse during acute COVID. And so I thought that was a kind of weird thing that I've seen it, I've heard of it before with other illnesses, but it was just surprising to see a number of reports in COVID as well. Do we have any better data to actually look at DEE kids? And unfortunately, we don't. That's the long story of this. To make a long story short for this webinar, there's no good data looking at our population, and it's very frustrating. But we can extract data from other sources and try to piece together a bit of a picture here. So I pulled a couple different studies. There's a Canadian study that looked at 75 kids with severe COVID. So these are kids that were either in the ICU or needed at least some level of respiratory support in the hospital. The most common associated condition, pre-existing condition, was a neurodevelopmental disability. 13% of kids had that. Then 12% of kids had obesity. Another 12% of kids had epilepsy. This is very similar to the data that Anne showed earlier, that we're seeing a common theme here, that kids with neurodevelopmental disabilities, with epilepsy and other neurologic disorders are it's one of the higher comorbidities that we see associated with more severe COVID courses. And when the CDC reviewed 2,500 pediatric COVID admissions, they found between 9.5 and 11% of kids, depending on which wave of COVID. So that ranged from Alpha, Delta, and Omicron waves. And those were all associated with neurologic conditions as well. And then there was an Italian study that also looked at adults with epilepsy, but they particularly, they were able to classify adults with epileptic encephalopathy. These are generally patients in their kind of young adult age, 18 to 25 or so, that had epileptic encephalopathy, and there was a risk factor for becoming hospitalized for COVID. So having epileptic encephalopathy and being on multiple seizure medications, which most of our patients are going to be, did increase risk of hospitalization with COVID. And then finally, there was a CDC study that looked at 121 pediatric deaths from COVID. And they saw that they have a kind of a broad category of neurologic developmental condition. And they said that was the third most common comorbidity after lung disease and obesity associated with pediatric death from COVID. So what can we take away from this data? I think COVID poses a bunch of it's a serious and unique challenge for the DEE community. It affects how we care for kids, where we care for them, and what complications they could develop from COVID. The virus is generally mild for most kids, but that's not going to be for all kids. And I do worry, and I've seen it firsthand, that our population is going to be at higher risk due to neurological and respiratory conditions. And so, and also for a fair number of our patients that are on steroids for treatment of their epilepsy, whether it's infantile spasms, ESES, or sometimes LGS. And so it's not uncommon that we treat difficult to treat epilepsy with steroids. We're weakening the immune system. Kids are going to be more vulnerable to COVID. There's a lot that we don't know about COVID and DEE, but we do know the vaccine is safe, well tolerated in millions of kids. There's at least some kids that have with DEE that have received the vaccine and done well with it. We don't have enough data. I wish we had more. And that's why we hope that you'll help us out with the survey as well. And I think the most important thing is talking to your pediatrician, talking to your pediatric neurologist, talk to them about the safety of the COVID vaccine and what that means for your child, because there are going to be unique considerations. Like if your child is on steroids, sometimes we delay the vaccine until if it's a short course of steroids, we'd rather them be recovered from steroids. Or if there are patients that have there are certain syndromes that are very sensitive to fever. And so talking to your doctor about what you can do if you have questions about the COVID vaccine, and hopefully get some answers. Thank you.
Thanks, Dan. That was really a lot of great information. All right, Tina, let's hop over to you.
All right, let me get my screen share.
As you're working on that, I think I fixed the chat. I don't know, folks. Feel free to try it again. Apologies for that. All right, the floor is yours, Tina.
All right, and are you able to see my screen okay?
Yep, looks great.
Perfect. Well, thank you so much for the opportunity to speak today. It's really an honor to be here with all of you. My name is Tina Sosa, and I am a pediatric hospitalist at Golisano Children's Hospital in Rochester, New York. And I would completely echo everything that Dr. Berg and Dr. Freedman have spoken on today. And I hope to add a little bit to the conversation from the perspective of a general pediatrician and someone who cares for hospitalized children specifically. as well as to get into a little bit more specifics about some of the data that's been discussed related to the vaccine and how that played into the approval process specifically for our younger children. So I will go ahead and get started here. So I think you've heard a lot of great discussion today about the importance of vaccination, the safety and effectiveness of vaccines, and some specific conversation around how that impacts children with DEEs and epilepsy syndromes. As a hospitalist, I care for children who are admitted to the hospital with many general pediatric conditions. So anything you would see your pediatrician for, but if the child's sick enough to be admitted to the hospital, they're often cared for by a hospitalist depending on where you live. Many of the children that I care for are children with medical complexity, many of whom have epilepsy syndromes and a variety of other chronic health conditions, and then have an acute condition that's bringing them into the hospital. And so I've cared for many children who have been acutely sick with COVID-19 infection, but there's also a number of other scenarios related to the pandemic that have led to hospitalization that I want to highlight, some of which have already been mentioned, but I have cared for many children who have had the multi-system inflammatory syndrome, or MIS-C, that was mentioned, and vaccination is one of the primary ways we now know to prevent that post-COVID complication, which can lead to significant medical complications and even death in some cases. I've also cared for many children with epilepsy syndromes and other chronic health conditions who are admitted to the hospital only because their caregivers, so their family or caretakers, are sick with COVID and are so sick that they're unable to take care of them, which places, of course, we never want children to be in the hospital at all, is our ultimate goal, but especially when they're well, they're in the hospital, they're then being exposed to things while they're in the hospital, and it places additional strain on the healthcare system. So that really emphasizes the point that you've heard about getting those around your child vaccinated is super important. I've also had children stay in the hospital for a very long time after having acute COVID because their care needs are so much greater after having a COVID infection. So I've cared for a few children with epilepsy syndrome who've been very sick in the intensive care unit, and then have had a prolonged hospitalization following that, and their new normal requires so much additional resources and care at home that they're unable to go home with their same care plan, whether it be from family or from home nursing, and they either need to have significantly increased hours of home nursing or transition to a long-term care facility, which is very difficult to find, especially now with the staffing and resource issues going on with the pandemic. And then I've also had children who currently reside in a long-term care facility who've been unable to go back, even though they're medically ready to go home to their facility because of outbreaks in the facility itself. So COVID really has a lot of impact on not only children themselves, but the whole system and how they're able to successfully live high quality lives. So you've heard probably a lot discussed about how, luckily, and we were very fortunate, especially early in the pandemic, children had less of a negative impact from COVID than older adults did, certainly. And that has changed. We know with especially the recent Omicron surge, we had a lot more children sick and in the hospital than we did with previous variants of COVID. But I wanted to share a few slides because I think it's helpful to put in perspective what COVID has done with respect to death in our children as compared to other vaccine preventable diseases, because we know many families who vaccinate against a lot of other diseases still have hesitancy surrounding vaccinating against COVID. So these slides come directly from the FDA and CDC meetings where experts met to discuss whether or not they were going to give emergency use authorization or approval to the COVID-19 vaccine for children. So this slide is showing you along the left-hand side, the age of children, the time period looked at, and then the average deaths per year. And at the time this slide was reviewed, when they were looking at approving the vaccine for 5 to 11-year-olds, I highlighted in red COVID-19. They were looking at 5 to 11-year-old children from October 2020 to October 2021, and they had 66 average deaths per year, which, as you can see, far exceeds the number of deaths in children from all of these other vaccine preventable diseases over a substantially longer period of time than just looking at COVID specifically. So this is pretty strong evidence that if you're vaccinating against other diseases, definitely makes sense to vaccinate against COVID-19. And then similarly, this is a slide from more recently when they were looking at the approval of under 5-year-olds. This shows the disease on the left-hand side, followed by deaths per year. In the middle, you can see COVID-19 is highlighted. And deaths per year in the 2020 to 2022 range in 5 to 17-year-olds was reported as 117 to 364 for COVID-19, which is significantly higher than several other vaccine preventable diseases listed along the left-hand side. So I think this is something that I talk a lot about with my patients who are choosing to vaccinate against other diseases as evidence why we should be doing it for COVID as well. Now, there is a publicly available podcast that is also on Twitter, Facebook, and Instagram, and they make really great graphics related to COVID-19, the COVID vaccine, and many other hot topics in healthcare specifically. It's called the Unbiased Science Podcast, and I really encourage everyone to check it out. It's run by an immunologist and a public health expert, but they walk through a lot of this data in a way that I think is really clear, and so I wanted to include some of their graphics here. Surrounding when the vaccine was approved for children. So this came out when the ACIP, the branch of the Center for Disease Control that looks at immunizations, recommended the Pfizer vaccine for children 5 to 11. They pointed out no adverse events of special interest. Efficacy against symptomatic infection back in November was around 91%, and then went into the dosing schedule, and benefits outweigh the risks. So this was really exciting for all of us who were seeing these kids with COVID in the hospital. We've been waiting a long time for the vaccine to be approved for the 5 to 11-year-olds. So this was wonderful news, especially related to the efficacy, but also the safety. And then this was more recently when they looked at the 6-month to 6-year age for Moderna and the 6-month to 5-year group for Pfizer. And I think it was really notable that it was a unanimous recommendation of expanding the emergency use authorization to these age groups, and that the doses had been adjusted, and these trials were done really thoughtfully to use the lowest dose possible to reach an effectiveness level that was helpful, but minimize any side effects. So those are really critical points that I talk through with my patients all the time. To go through a little bit of a summary of some of the data related to the side effects more specifically. So for Moderna, for kids under 6, it's 2-dose regimen 4 weeks apart at a reduced dose compared to that used in adults. So it's a quarter of the dose, tested in almost 7,000 children under the age of 6. And depending on the definition of COVID case used, the efficacy against symptomatic illness ranged from 43 to 53%. But I think what was discussed earlier, and I would emphasize too, is we know the most important outcome that we're worried about is severe disease leading to hospitalization and death. And we think that the vaccines are likely much more effective than these numbers in preventing those outcomes that are of chief importance. And then reactogenicity being similar to adults, some feel sick and feverish for a few days, especially after the 2nd dose, but all self-limited, pretty mild side effects that were observed in the trial. And then for Pfizer, similarly, a reduced dose, but a 3-dose series instead of 2. And then the efficacy reported after 2 doses was 28.3%. Again, that's against all infection. And then jumping to over 80% after a 3rd dose. And Moderna will be investigating a 3rd dose as well in their trial moving forward. And Pfizer saw even fewer side effects and really the same kind of mild self-limited side effects, fever, generally feeling a little off for a day or so, but then recovering very well. So I think we talked about most children who get COVID experience mild symptoms. And that's, taking into account again, that mortality and death data that I showed earlier related to other vaccine preventable diseases, still most kids will do well. So why should kids get the vaccine? And I think we've talked about some of the other important reasons why both children and their caregivers should get vaccinated, but this walks through a few things in more detail. The benefits of vaccines far outweigh the risk, and there's a lot of different benefits and risks that we can talk about. And I think Anne's discussion about myocarditis is particularly important. And I think the take-home messages for that are a few things. One being the risk of myocarditis from COVID infection is significantly higher than the risk of myocarditis from getting the COVID vaccine. And the severity of myocarditis from COVID infection is profoundly worse than the severity of myocarditis that comes from the vaccine in very rare cases. So the myocarditis we see from COVID infection is much more likely to lead to prolonged hospitalization, intensive care unit stays, and even death. Whereas, as Anne shared earlier, the myocarditis that has followed some rare cases of vaccination is predominantly self-limited, leads to hospitalization in some cases, but much less likely to end up in an ICU stay. So I think that's very important to point out as well. And the death toll in the past year puts COVID-19 in the top 10 causes of death for children ages 5 to 11. And we've talked about a lot of the other, death is important, but there's a lot of other outcomes that are not insignificant, including long COVID, which, as Anne shared earlier, vaccination has now been shown in the data to prevent those complications, including multi-system inflammatory syndrome, as well as the other really debilitating symptoms of long COVID that we're starting to see in children and have not figured out exactly how to treat or cure at this point. And children contribute to the spread of COVID-19. So even children who get COVID and do very well and have mild symptoms, we know that people who are not vaccinated and get infected are more likely to transmit the virus to others due to the viral load that they have, how long they are sick, a lot of factors. And that not only impacts public health by potentially infecting more additional individuals, but also it perpetuates the development of new variants, which, as we've seen all these different variants over time, and we can't really speak to what the severity of those variants will be in the future. So vaccination is critical to preventing those for all those reasons. And so myself as a hospitalist, I think a lot about how we can optimize chronic care for children while they're in the hospital with an acute illness. How can I help keep them healthy and safe and not have to come back to the hospital? And so inpatient COVID-19 vaccination programs have been one way that we've been able to do that, is offering the vaccine to children when they're recovered from their acute illness and getting ready to go home. And I will say from our perspective, one of the populations we focus most on trying to get vaccinated before they leave the hospital are children with chronic medical conditions like epilepsy and other conditions that place them at higher risk of having severe COVID and long complications if they were to get an infection. So we were able at our hospital to implement a process to offer the vaccine to children in the inpatient setting. We vaccinated many children since we rolled this out in last December, and we help to arrange for appointments for subsequent doses if children need them. So that's something we've been doing kind of on the inpatient side to try to prevent future infections in our kids who've already been in the hospital for one reason or another. And then I think it's important for us as pediatricians and as scientists to talk about how we need to walk the talk. So we can go out and start vaccination programs and talk about the importance of vaccines, but these are also things that affect not only our patients, but our own families. So I really found this to be profoundly important when the vaccine came out initially for healthcare workers. I was pregnant with my second child. I decided to get the vaccine when I was pregnant. And then I enrolled in some studies surrounding people who were vaccinated in pregnancy and following outcomes, and how we now know that provides benefit to children after they're born if the mother's vaccinated during pregnancy. And then both of my children have participated in the vaccine trial. So my son Brandon, who's now 4.5, when he was 3, he participated in the Pfizer phase 1 trial back in April of 2021. And then my son Leo, who was 9 months old at the time, is still enrolled in the Moderna phase 2/3 clinical trial. And I know innumerable healthcare workers who have cared for children and adults with COVID who have enrolled themselves and their families in the trials because of recognizing the importance of vaccination in preventing disease and saving lives. So that is all I have, but again, thank you so much for having me. And I can't emphasize enough the importance of talking with your pediatrician and also your neurologist about the considerations of vaccination for your child. And thank you very much.
Thank you so much, Tina. That was fantastic. And I loved seeing your little ones bravely stepping up to help understand these vaccines. So I'm going to now welcome Tracy Dixon-Salazar to join us. And she's generous enough to join us today to share a little bit about her family's experience with COVID-19 recently after avoiding it for a very long time. So
Yes. Hi. Well, thank you for having me. I really appreciate it. And I love looking at all the slides that everybody shared and seeing the data. I'm still processing all of this, so I'm not really sure what's going to come out of my mouth or if I'm going to burst into tears at some point. But my daughter Savannah is 29. She has Lennox-Gastaut syndrome. She had her first seizure at the age of 2, and out of the blue, no family history, no precipitating event. And then we had a couple more and then went 6 months without having any seizures. And we thought, phew, dodged a bullet. No. At 3, the seizures came back. She started having multiple types of seizures. She was diagnosed with intractable cryptogenic epilepsy, and no cause was found for her seizures. Everything that we tried, we started medications at that time, nothing worked. And she seized every day. A good day was 5 to 10 seizures. A bad day was hundreds, too many to count, for the next 16 years. So until she was 18. She wasn't diagnosed with Lennox-Gastaut syndrome until she was 5. And we thought she had gotten the diagnosis, like, phew, oh, we finally have a diagnosis. What we didn't realize was LGS was yet another diagnosis showing that something had gone horribly wrong in her brain development because of all the seizures. And now she had a network disease. We didn't know that back then, but we know that now. And we lived 16 years in just utter hell. Many of you on this call, if you are caregivers, you know, living in crisis mode all the time. She was getting injured. She was seizing. She was falling. She was breaking bones. She has multiple skull fractures. We remember life before rescue meds, at-home rescue meds. So we spent a lot of time in the ER. We're on a first name basis. Now, and we were giving rescue meds 2 to 4 times a week to her for just well over a decade. And she's been put in more medically induced comas and had more bouts of aspiration pneumonia than I can count. And we've resuscitated her a few times over that period. When she was 5, I was very uneducated and went back to college, or went to college. I'd never been. And that's another story for another time. But somehow I'm more surprised than anybody. Ended up with a PhD in neuroscience. And I was a postdoc in the research lab when Savannah was 18. And genetic testing really was blossoming as a new testing method. We were pioneering it in our lab and found the cause of Savannah's epilepsy. She has calcium channel overactivation disorder, put her on a medicine that reduced her seizures by 95% and stopped her status for 11 years until COVID 5 months ago. So 5 months ago, we did get her vaccinated, and I have a long history. You know, I have a very checkered history with vaccinations and feelings about them. As a scientist, I feel one way. As a mother who works with the LGS community, I feel another way. As you know, somebody who loves immunology, I feel yet another way, right? I have a lot of feelings about this. So, but we did get her vaccinated. We all got vaccinated, and we managed to not get COVID until most recently, which is great. We were very afraid that if we ended up in the hospital when everyone was in the hospital, that she would be triage to don't treat. And we were afraid of that because there was overuse of the system for sure in the beginning. She got COVID, and her and I both had a horrible reaction to it. We were 4 days of a pretty high fever. Mine got up to 105, hers got up to 103, about 4 days. We were able to bring it down each time with medicine, but then it kept spiking again. And then after it was over, we had upper respiratory symptoms. So no lower, just upper for the next month. And where I slept for the next month and was exhausted, and she slept for the next month and exhausted, I was better by the end of the month and she wasn't. And in month 2, she slept through the whole month of month 2. And at the end of month 2, she started having seizures again and going into status. And in the second month, she needed rescue 16 times. So we were freaked out and are still freaked out. I don't know. I mean, she's been worked up in immunology. It doesn't seem to be multi-system inflammatory issue. I don't know if this is the LGS, which is a network disease, and we've just now activated the network, and the network is pissed, and the network wants to make more seizures and more status. And That's just what it does. I don't know if this is the sleep, the excess sleep. There's definitely an interesting relationship between sleep and seizures. And I don't know what this is COVID, if this, what of this was the COVID virus itself. I know this all started because of COVID. So we are, I think I'm now officially post-denial. I was in denial. It was beautiful for several weeks, about 4 weeks. And now we're aggressively trying to get things under control. We did try a new anti-seizure medicine recently, and her seizures increased to hundreds a day again. And so we were able to take her off that medicine. She was on it for about 5 days. And now we're just, we're back at that place where we're living in crisis, and we're praying to anyone that will listen. And, and I think, I look back again, we struggled with, should we give her the vaccine? Because she has this neurological condition. We struggled with, understanding, the technology, especially in the early years. I mean, I used to be a non-believer in vaccines, and I used to not trust the government. And then going through my years and years of schooling, and the more I understood about these treatments and what we understand about the immune system and the nervous system and biology, and we're very good at making vaccines. And the disease is so much worse. The disease is always worse. I mean, I had to learn this lesson with seizures too. I always used to wonder if seizure meds were worse than the seizures themselves. And I had to learn that the hard way too. So I don't know what awaits us for Savannah. We're still working with immunology. We're working with our neuro. We're, if you know any gods that we maybe haven't prayed to yet, please email me. But that's been our experience. And, I think I am definitely a convert. I think vaccines are really important. The disease is worse. And you saw data here to show you that disease is worse. And, we sort of missed our window to eradicate this disease. Now it's going to be around for a while. We could have gotten rid of it, but we didn't all want to vaccinate, and that's fine. I mean, I do believe it's a personal choice, but having learned the hard way. I will say that just the last thing is just, I do think Savannah, the fact that this didn't move into our lower respiratory center, even though we did have the high fever, which is kind of common. We tend to get pretty bad flus, her and I in general, right? When we have had the flu in the past. I think it could have been so much worse. So that's where we're at. I managed to get through that without tears. Sorry if I went over time, but yeah.
Well, I was tearing up and I got chills. So it's so heartbreaking. I know. Well, it's just the reality, and I'm grateful that you're willing to share, because I know it's been a really, really hard time. And
well, now I'm going to cry. Thanks, Gabby.
Love you.
Just kidding.
But
yeah. I mean, it's a personal choice. You know your kid the best, but you've seen some beautiful data here on vaccinating and on what it's like to get the disease. And then, if you want to come co-commiserate with us here in the developmental and epileptic encephalopathy world, I think many of us have, stories where we're trying to navigate this together. So we may not have cures and answers, but we have each other.
Right. Well, certainly. I have a couple of questions that came my way, and if anybody else who's on with us has a question, feel free to drop it in the chat or the Q&A. But how have things changed now that things are approved for 6 months and above? I think there's a large group of people who have been waiting for this to open, either anticipating it and saying, I can't wait till it happens, or saying, I don't know what I'm going to do when that happens. What can you tell us? And Tina, you touched on it a little bit, but is there anything that we're learning about this 6 months to 5 years group? What can you guys tell us that we may not already know?
I think one thing that's been really encouraging, and Anne talked about this quite a bit in her talk, was the myocarditis concern has not showed up in any of the younger age groups, which again, I think I would drive home the point that there's been a lot of concern that COVID vaccines came out really quickly, and were they rushed, and all of those questions are very valid. But I think the reality is, especially for the mRNA technology that's been in development for decades, so we, in the setting of a pandemic, we're able to mobilize resources to get this out, luckily, with the speed that we did. But there was no, concern that the study of mRNA technology didn't happen in a rigorous way. And both prior to the vaccine coming out and especially since the vaccines have come out, there's been no vaccine in history that's been as rigorously studied as the COVID vaccines have been. And all the vaccine companies, Pfizer, Moderna, have made adjustments along the way. And these trials have been done in a very rigorous way. I can speak from my own experience having my children in the trials. And so that's why those doses have been decreased to minimize side effects. And we haven't seen the things like myocarditis coming out in the younger age groups, which has been great. And so many, now thousands and thousands of children have been vaccinated and the safety and efficacy has held up. We have seen these new variants coming out and the vaccines were sometimes more effective against some variants than others. But I think the critical point is the severe infection and death is the big outcome that we want to prevent. And so we're fortunate to see the vaccines working in that way.
Thanks, Tina. We have a question about if there's evidence to support that these vaccines prevent or reduce transmission.
So the vaccines are not transmission blocking. They don't completely stop transmission, but there is pretty good data to suggest that they reduce transmission. Mainly, there's some data that they reduce the transmission within the household, but then there's even data also that they are limiting the duration of illness. So if you're sick for fewer days, you transmit for fewer days also. And so there's kind of twofold effects on reduced transmission. It's not, there are certain vaccines that are like sterilizing vaccines that truly block all transmission. These aren't quite that level, but they're pretty good. They do block, they reduce a significant amount of transmission. We just don't know exactly what percentage, but I've seen data that show anywhere between 30 to 40%. Even I think there's one study as high as 60-something% within a household reduced transmission. So I can add those studies to the end of the webinar also.
Thanks. Yeah, and I think there was also a question that came my way about long COVID, and I think that was touched on a bit here. But in terms of, and certainly in Tracy's and Savannah's situation, we see that neurologically, there is a real retriggering of maybe something that had been dormant and controlled. So, do we know if there is any evidence of ongoing neurological challenges or respiratory challenges for or other kinds of issues for those with DEEs? And we may not know.
Yeah, I'm not sure if we know specifically, but we do know that in general, there are more neurologic signs and symptoms following infection, more severe infections. And I think that I'm still very much struck by that paper I showed by LaRovery and colleagues as a remarkable study, 50-some hospitals across the country, maybe even beyond that, the neurointensivists and intensive care people got together to study children with COVID. And some of those complications are not going to go away. And the ones who were more likely to have neurologic complications of COVID were those who had pre-existing neurological conditions. So we can make some inferences. I don't think we have great data, though, beyond that.
Yeah. All right, I've got one more question, and unless any others pop up in the chat or Q&A. One is about any thoughts about anti-seizure medications and infections or in susceptibility. And Dan, you touched on when we treat with steroids, that's a clear challenge. Do we know anything else about other anti-seizure medications and how they may impact either infection risk or treatment?
There really shouldn't be too many other meds that would decrease your immune system's ability to fight infection. Steroids are definitely the main example. And there's there's different ways that we use steroids for epilepsy. And so it would depend on how kind of it's prescribed and what dose is used to determine how great a degree of immune system compromise we're talking about. But oftentimes for epilepsy, we're using pretty high doses. So you can expect that there's going to be some weakening in the immune system. And that's why we try to, educate families as much as possible when we do that. So yeah, other than steroids, though, I can't really think of any other meds that would be, not at least not on the ones that we commonly use to treat epilepsy.
Thanks. We have one more question that came in are there any thoughts on continuing isolation? We know that a lot of our rare epilepsy families have been in deep isolation for years at this point, not to mention that before COVID, they were also living quite isolated lives, but this has exacerbated it. But are there any changing thoughts on guidance around school being out in public? I mean, I think there's a lot of complexity to this question, and we may not have the right answer. And I'd love to hear from the clinicians, and also Tracy, maybe if you're in your, I mean, you've got a large community, love to hear what people are saying in the LGS community. So Tina, any thoughts? Yeah.
Yeah, I think the overall message would be we have great data now on the effectiveness of things like masking to reduce, not eliminate, transmission and the protection that provides, as well as isolation, distancing, all of that. Now, what I would also add to that overarching comment is that this really needs to be a conversation with your pediatrician and your pediatric neurologist to talk about the risk in individual scenarios. Because, you know, and this is speaking as a general pediatrician and speaking as a hospitalist and as a mom, interaction is very important. And I think Anne mentioned earlier, like isolation also has very significant negative health effects, and that has to be balanced with the risk of COVID infection and other types of infections as well. So I think it really needs to be a personal individual decision with your own medical team. I will say in general, what we've been talking a lot with our patients about is if you're fully vaccinated and boosted and you're taking protective measures like masking, and, you know, making sure you're not around people who've been exposed, there's lots of different layers to this. There is certainly a lot to be said for re-entering activities, therapies, things like that in a way that's safe and in a way that's individualized to the scenario for your child and your family. But I think now that we talk about layers of protection, we have so many things we can do like vaccines and masking and taking, you know, into account what kind of environment you're going into and how risk is being mitigated in that environment. We hope that all families, including families of patients with DEEs, can re-enter a lot of those activities they used to do. But I think the biggest point is having a conversation with your medical team about that.
And I would just say from where our standpoint is, I mean, it is a struggle. We see a lot of people in our community that are just done and need to get back out there for their own mental health and welfare. You know, and we, the Tuberous Sclerosis Alliance and the Dravet Syndrome Foundation, we all have had our conferences recently. 2 of us have already had them. We had, you know, 300 people in Texas, and we mandated masks, and we had very minimal exposure and COVID outbreak. We had none during the meeting, and we didn't hear of any kids that had developed COVID from the meeting. And what we've noticed, though, I mean, there was a lot of grumbling, don't get me wrong, but the families, it's like once you said like severe population, sick kids, they were fine. But what we did notice was that the most severe kids stayed masked, which is interesting because you would often think the most severe kids would not mask, but the ones that were really worried about getting it, that family masked. And that seems to be the trend. Like if you're worried about getting it, you're the one that has to take the onus of masking because nobody else is. And Dravet Syndrome Foundation, same thing. They had some cases. They had 10 cases from 4 families, and they were all sitting at the same table in a closed room. And it was interesting because there were other people at the table who have never had COVID that should have gotten it. They were sitting right next to the first patient that reported it, and they didn't. And so, you know, it's just, it's out there, it's everywhere. Can we really shelter forever? I mean, these are all just like, why do we even have to have these, like, just give us one more hard thing to deal with, right? In DEE, right? But it's an individual decision, and it's a tough one to make. I mean, we were sheltered. We were doing everything right. We were going nowhere. I don't even know how this got into our house. We were masking everywhere and hand sanitizing, and nobody went anywhere. We were sheltering except for the grocery store to get food and to the doctor. And even then we were trying to do telemedicine and we still got it. So
Yeah, that speaks to, it feels like with so many of these DE families have avoided it for so long, but it's kind of starting to infiltrate more and more, even when there are very minimal interactions. It's just the infectiousness of these new mutations is really wild. There is another question about vaccine dosage in the chat. I don't know if you guys saw that, Tina and Dan, but about the third dose, and if there's any empirical evidence on the results, like what happened in Israel. That was not a very good synopsis, but.
I'm gonna have to defer to people with more expertise on this one.
I think this is saying UK uses a third of an adult dose of Pfizer over 2 doses. The data show how important the third dose is. Is there any empirical evidence on those differences with the US dosage and results? Do we know what Israel numbers are for children? I do not think there's been any like head-to-head studies done on that I'm aware of. Like we haven't, I think a lot of the discussion here has been comparing, people talk about comparing Pfizer and Moderna, and there also haven't been head-to-head studies to even compare that. So that I'm aware of, we do not have robust high level of evidence data comparing that. I will agree though with the sentiment regarding third dose and the importance of that. And I shared some data about the third dose of Pfizer increasing the efficacy in the trial from less than 30% to over 80%. But I will emphasize the sample size and numbers were very small. It was like 7 cases when they looked at second dose compared to third dose and making that jump. So I'm hopeful that, as uptake of the vaccine increases in the younger children, we'll have more and more data to support not only what's going on in the US, but also comparing with other countries. Because, and I did mention as well, Moderna is planning to start trialing a third dose in their company to my son who's in the Moderna trial. They've already started talking about expanding that to a third dose as well. So I think some families who made a decision about Pfizer versus Moderna with the difference 2 and 3 doses, it may end up being equivalent regimen regardless of which brand of vaccine is chosen. But I'm not aware of specific data on that, but certainly hopefully more will be coming out in the future.
Great, thank you. I'm going to take a quick minute just to share a little bit more about this survey that we're doing, because we had a question that came through. Thank you for setting me up to talk about this. So far I mentioned we have about 60 responses from a variety of different communities, which is really incredible. Our goal is to reach 300 at least, which is a little ambitious, but we think that all of you will come through and help us. We are hoping to learn a little bit more about decision-making around vaccines, what's making families decide to vaccinate or not vaccinate, and if there are side effects to any of the vaccines and what those look like. We're asking about whether people with DEEs have contracted COVID, and if so, the severity of the infection and ongoing symptoms that are lingering, and a little bit about telemedicine. But it's a pretty quick survey. It takes just about 10 minutes. And our hope is that we will really be able to gather the data that does not exist. You heard everybody say it here a lot today, that we don't know about specifically the experience of COVID-19 for those with DEEs, because there just hasn't been any research. And that's what we're aiming to do, is to kind of fill that gap so that caregivers and providers can make more informed decisions. So the results will be shared on our website, on our social media channels. We're putting out information, and also in a follow-up webinar, we hope later in the year. We hope to publish these results so that they can become part of the the world of when people are looking for information about how to treat and care, that will come up. And then if we get sufficient numbers, we also hope that we can then share that information back with these specific disease groups. So if we get a good chunk from LGS Foundation will say, here's the data that we've been able to now analyze on your community, and you can speak specifically to what's happening in your community. So that is our hope. This is the way to reach the survey. I put it in the chat as well. It is on our website. You can scan here. And thank you. We'll see you guys again in the fall. We are taking a break for August because there's a lot of stuff to catch up on and to prepare for the fall. And if you have ideas about what you'd like to see in a future webinar, please write us at info@deepconnections.net. We really work to follow the lead of the community in what you guys are needing and wanting. So that's what we're going to follow through with. We've got some really exciting ones coming up in the fall around oral and dental care and a number of other different topics, but we'd love to hear from you. So thanks, everybody. A huge thank you to our panel today, Tina, Dan, Ann, and Tracy, for sharing your experiences, your expertise, your personal. We're grateful to you for that, and we'll see you guys next time. Take care, everyone.
Thank you.